Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. It's very great pleasure to be here for this very important and prestigious seminar. I would like to present my paper on strengthening health promotion and preventive care program, and this is the case of cardiovascular disease. I'm Laksono Tisnantoro from Department of Health Policy and Management. So the outline of my presentations is as the following. One is the burden of cardiovascular disease in the global and also in Indonesia. And then secondly, the supply side of cardiovascular disease services, the cost of CVD in JKN, and then the problems of equity and prevention. And this is a very important issue that we have to look at how to prevent the CVD. And one of the important issue is the use of the principle of innovative health. And then lastly, the case of hypertension. So I will start with the burden of cardiovascular disease. If we look at the data from HME in Seattle, that's due to CVD is increasing. And especially for Indonesia, we have a sharp increase of deaths due to CVD. This is from HME, and also it is very important to understand that also the quality of life also becoming deteriorating. So disability adjusted life year is also increasing in Indonesia. So this is the picture of the burden of disease. And then if we look at the prevalence of CVD across provinces, so based on risk studies of 2018, at least 15 out of 1,000 people, or about 2,784,000 individual, is suffer from CVD. So 2 million, almost 3 million. And then if you look at the provinces, it is varied from 2.2 to 0.7. So this is the prevalence of CVD across provinces, and the average is 1.5. So the highest level of prevalence is the North Kalimantan province, 2.2, and then also here in Yogyakarta is 2%, and then Gorontalo 2%. And also there are eight other provinces with higher prevalence when compared with the national prevalence. So those 8 provinces are Aceh 1.6, West Sumatra 1.6%, Special Capital Region of Jakarta (DKI) is 1.9%, and then West Java 1.6%, Still Java 1.6, East Kalimantan, North Sulawesi, and also Central Sulawesi 1.9, 1.8, and 1.9%. Okay, so now the big question is how the supply side, hospitals and medical doctor specialists distribution. Is it enough or sufficient to cover all of the medical needs under this burden of disease across provinces? So let's go to the supply side of the cardiovascular disease services. So if you look at the availability of cardiologists, this is the number of cardiologists as June 2020 from MOH. So the majority are in Java and Sumatra. And actually, if you look at this, we have to invest in education for this, like investment for making more and more cardiologists, but it is not easy. So by years, the number of cardiologists is clustering in Java Islands provinces. It's very clear. Although the number of citizen is high in Java, but still the comparison is too low for province in Maluku, in North Kalimantan, in Bengkulu, in Papua. So we need more cardiologists. And then if you look at again, back to the issue of the burden of the disease, the prevalence is not matched. So if the number of cardiologists as June 2020, we look at how the province's distribution of burden of disease is not well matched, is somehow is becoming very different picture. Okay, so let's go to the map of the availability of cardiovascular disease service in hospitals over Indonesia. If you look at the medical service of cardiologists, again, it is clustering in Java. So this is the cardiologist, again, back to the map. And then if you go to the coronary artery disease specialistic services, also here the picture is still limited and concentrated in Java, with some concentration in Sumatra. And then if we go to the rare specialties like the specialist service for pediatric cardiac surgery and hereditary cardiovascular disease, yes. So it's limited on to the big cities in Java, Sumatra, and South Sulawesi. Yeah. So this is very, very important issue. And then if you look at cardiac catheterization service, also is not well distributed. Okay. That's why the portability of cardiovascular under BPJS varied across regions. So if you look at this graph, more and more patients come to Jakarta from outer islands of Indonesia. This is the picture. Okay. So if you look at province by province, it's also most of the provinces also sending the patients to the big cities in Java. So this is the picture of portability. Okay, and then let's go to the cost of CVD in JKN, and this is one of the biggest issue that make problems of equity. So if you look at the cost of cardiovascular service in the national health coverage in JKN, you can see that the cost is about 10.2 trillion rupiah in 2020. Okay, no, it's before 2020. So it's the biggest expenditure or the biggest claim in the JKN. It's much more than cancer, stroke, renal failure, thalassemia, hemophilia, leukemia, and also cirrhosis hepatis. It's very, very expensive to treat. And the number of cases is 13 million. It's a huge number of cases. It's not easy to say this is a big problem, but yes, this is very, very big problem. And then if you look at the progress between 2015 to 2018 by province, so you can see that most of the expenditure is also in Java province that increased sharply in DKI as well, in Jakarta, and also in Banten. But in other provinces, there are many provinces experience flattening or even decrease of BPJS claim. So from 2015 to 2018, and then this is a sample of 1% of the data BPJS. This is the graph like problems of inequity. And then if you look at who benefits, and mostly by the segment of PPPU. This is the informal worker, the green one, and the formal worker, yellow. Dominated expenditure, although the number is less than the number of PPE, APPN, the red one. So most of the user of the cardiology procedure in 2015 is the informal and the formal workers. So you can see this year by year. This is 2016 by province and by member. This is the 2017. Is so still the green and the yellow dominate the expenditure. Okay, and also 2018 the same pattern. So you can see that Indonesia suffer from very very big disparity across provinces and across segments of the populations of BPJS. So we know that BPJS has some segment, the PPPU, the green one, the PPU, yellow one, and then the PPA-PPN, the red one, and also the local government, PPE, small one. Yeah. And most of the user, they are PPPU and PPU. Yeah. And then this is the picture of the national aggregate of cardiology procedure claim by BPJS in the segment of not worker, PPA-PPD, and then PPA-PPN, and the PPPU and PPU. So the PPPU is the informal workers and only 30 million members, but the expenditure is quite high and steady increase year by year from 2015 to 2018. And the PPA-PPN for the poor is still very, very low for 96 million members, and there is like a trend of declining. We have to be very, very careful in this graph. But it seems that most of the user of the cardiology procedure claim in BPJS, they are the PPPU, the informal workers. And the PPA-PPN, not so many use of the BPJS. And this is the problems of equity. The point that I just raised, that most of the user of the GKN services, they are not poor. Okay. So let's go to the problem service equity. The financial cost of cardiovascular disease is the highest in BPJS Kesehatan. And then we understand that the distribution of the health services is not evenly distributed. And then also the number of cardiologists. And then if you look at Java provinces or hospital will use the most of claim for CVD. Okay, so if we look at across provinces, the region with more cardiologists get more CVD service. And then with claim system, the expenditure is spent more on regions with more cardiologists. And that means the poor people in the remote area, they don't have enough access to CVD services. So this is the picture of equity that not yet achieved. The equity principle should be like that. For the small people, they have to have like two boxes. But instead of two, at this time, the equality principle is like this, only one box. So the small people, they cannot see the things very, very good as the big boys in the lab. So this is the description of how the inequity of the medical service for cardiovascular disease. It's not easy problem. It's not an easy problem. Okay. So let's go to the prevention and promotion, the use of innovative health principle. So by understanding about the problems of medical services, so one of important strategy for reducing inequity is providing more preventive and promotion program. But we have to do this in parallel with the improvement of the supply side. Why? Yeah, we have to be in parallel, but we have to put more effort and preventive and promotion program. Because deploying more supply set takes time and huge investment. So you can see in the map that if we try to build like cardiovascular disease services in the remote area, it's not easy. It takes maybe years to go to have more medical cardiologists or more medical facilities to be deployed on or constructed in, say, in the hinterland of Papua or NTT or Kalimantan. And the point that the burden of disease for the CVD is all over Indonesia. So that's why we have to put more preventive and promotion program as the cornerstone of the health programs. So this is the point that we have to look at back to the issue of community program, how to strengthen of promotion and prevention. And the big question, what kind of prevention and promotion? So we have years of prevention and promotion program at the moment, and then not much result. Yeah, the burden of disease data still shows that the increase of the severe death in Indonesia is still alarming. Like this picture is increasing very high. So we need innovations in the prevention and promotion in terms of procedure, technology, policy, and also system delivery. And this is the one thing that the current government is trying to push the innovation in prevention and promotion. For this important issue about innovation, let's go to the WHO definition of health innovations. Health innovation is to develop new or improve health policies, systems, products and technologies and services and delivery methods that improve people's health, with a special focus on the need of vulnerable populations. So in this definition, we can look at the content of innovation. It's not only methods, but also how the technology and also the policy, the system, how the financial system of this innovation. It is like a discussion or maybe pointing a comprehensive way of doing things. Yeah. So innovation consists of many aspects. This is one of the interesting innovation for AIDS in Africa using the combination of high technology and low technology, internet and also SMS texting, how to improve communications and accountability between healthcare providers, laboratories, and parents to optimize outcomes for HIV exposed infants. So for primary care, yes, for the prevention, we have to look at a new way of doing things. Yeah. So this is not ordinary things, but we have to look at the innovative way of doing preventive and prevention program. Um, okay, and the principle is very interesting. Creating social impact. That means innovation plus scaling. So if you look at our problems in CVD, we have million of patients, 2.7 million of prevalence, but also we have hundreds of million of people that can be sick as well. So now how the innovations can be developed for reaching million of people. So this is the principle of creating social impact, innovation plus scaling. And USAID developed some criteria for promising innovations. One is the health impact, the demand sustainability, the organization and or partner capacity for scaling, yeah, and then progression to scale. Is there any problems in regulatory or technology? We have to solve the problems. So there are 4 tools for measuring the innovations to be a promising one or not. Right? So what creates an impact? So impact should be focused and committed scaling, which means delivering innovations to more people and doing this by more reliably, efficiently, and with ongoing improvements in quality. So we have to look at the target is not only 1 or 2,000 people, but also the social impact will be good if this impact will cover for million people. Yeah. Okay, so this is scaling. And then also development pathways. If we go to like a global health innovations, can scale through various pathways. One is commercially or in partnership with the private sector. Secondly, by through the public sector, by incorporating the innovation into the practice of developing countries, governments, donors, or philanthropists. Or C is through a combination of both. Yeah. So when we look at this kind of innovation, we have to look at how the financial aspect of this innovation. It should be supported by a strong source of finance. That means either government or private or both, the combinations. The question is there any case that can propose for innovative prevention and promotion, especially for cardiovascular disease? And this is uh, the cornerstone of my presentations. So let's see to the case of hypertension prevention. As we understand that from the risk study 2018, around 30% of Indonesians have hypertension. So that means around 50 million adults. This is like rough estimations. And so without any screening and proper treatment, it's simply that in the next 5 to 10 years, the number of 2.7 million will be increase sharply. Okay, so we have to look at how to screen and proper treatment for the hypertension that can slowing yes, or reducing maybe uh, the pace of CVD patient in the future. That's why we have to make a screening, early detection. Yes, how to detect the possibility of heart disorder or as a preventive measure towards a cardiovascular disease. So hypertension is one risk factor for cardiovascular disease. Although we have still many others risk factor like glucose, in the blood, also cholesterol, fatty, in the blood. So, but hypertension is also one of the cause of CVD. So we have to look at the screening for hypertension and then using state-of-the-art but proper technology for innovation. Again, back to the impact of this innovation is very important. So, how the screening innovation technology and its technology? That is the big question. To cover how many people can be screened. Is it possible to become a head innovation with a large scale? So this is very, very important question about hypertension. Because again, back to the issue of almost 30% of the Indonesian people, they are under hypertension. And this is the screening show that it requires many health equipment for prevention in household and community. So we can see that the large potential of the number of users is numerous, millions of family or people to be screened for hypertension. And the technology is used is low technology. It's not medium or advanced one. It's low technology actually. For example, we can have like digital tensimeter and should be supported by apps and digitally based primary care general protection system. So this kind of screening system should be connected with primary health ecosystem through apps and telemedicine, which is centralized and then managed by a trained general practitioner. And then also becoming digitally networked and by the supply of drug and also maybe herbal medicine. So this is this kind of things. Maybe we can imagine how the primary care doctor can have like a screening using a simple digital tensimeter. And the screening is to be performed at neighborhood level with the participant of the committee. And then the result is sent to primary care doctor. And then the primary doctor provides recommendation for prevention and medical treatment which is connected with the referral system. It's very important that screening will identify people who have the hypertension and how to treat maybe the borderline hypertension or maybe the mild hypertension or the severe should be very important to be planned in the future. And also the primary care doctor is also connected with drug and herbal medicine procurement system as well as other evidence-based provision for prevention and treatment of non-communicable disease in pharmacy. And then also there is a form of organization based on telemedicine with an app. So this is the so-called high technology or the latest technology for this. and will integrate several physical examination and laboratory herbal medicine as well as drug prescription. And now how about the finance? This is very important. In this innovation, there's a network of health equipment producer and regions that maintains the equipments and to ensure the region's supply. So behind this scheme, there's a industry that also working on this issue. And there's also a sustainable financing system, including from the community, philanthropy, government, even under BPJS. Yes. So this is the finance of the system. It looks complex, but actually when we look at who can start with this kind of innovation. So when we look at the criteria, that we can see that we have to look at who can start with this kind of innovation. The health impact. Can this innovation reduce hypertension-related diseases if compared without screening? Then our health workers and other stakeholders able to use this innovation and finance it so that it becomes sustainable. And then how the capacity of scaling up and then also the progress. Can it be proven? So this criteria is not easy. So I think in this point, as a closing, university-based global health initiative research development is the place for trying or make a first experimentation about this kind of new innovative way in promotion and prevention for CVD. Because university, it has interdisciplinary research, including the production of non-communicable health equipment. So the policy and technical analysis, education, capacity development, and also advocacy to design and scale up health innovation is within university capacity. And also for integrating resources for hypertension-related disease screening. It is very important for having financial resources. And then push for policy making in the prevention of hypertension. And then also how to make reformations and development of the multidisciplinary approach that support the adaptation of non-communicable disease prevention innovation. So this is very important. This is a new thing for the future. It's not only a traditional prevention program. Also, how to have a network to extend the coverage. And the university, they have also networking and also partnership with private sector and philanthropists. So these are the things that makes university becoming very important prime mover or the first actor for this global health initiative in terms of screening. But also we have to look at the sources of failure of innovations. One innovator doesn't truly understand the problems that they are trying to solve. Innovators are not able to overcome technical obstacles during development process. And then the good services are too expensive to be used in the large scale within the context of low and middle income countries. And then good services are not valued and not understood by primary stakeholders. And the team is not able to navigate transition from academic or becoming a startup form organization that is able to scale up. So there are some sources of failure of innovation in the also can be used in hypertension screening. So this is the end of my speak. Maybe let's discuss it together. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.